Okay, thank you very much. As you already know, David is quite busy and he didn't want you to have this presentation pre-recorded, but you can have a live presentation. So that's why I'm going to give it for you. I'll share the screen. Here it is. 1 second. Okay. Uh, this is the ICS lecture, and it's about the injectable urethral bulky agents for stress urinary incontinence. Okay, so you know that we have had many type of surgeries for the stress urinary incontinence. And although the injectable agents sound quite new, they were introduced in 1938. And the last technique to get in the surgical armamentarium were the synthetic slings. And they have stayed because we know that the cumulative experience in 20 years is that they have a very good continence rate. Of course, yesterday we have already told that it depends on the definition of success, but they have stayed as the gold standard for primary surgical correction of the stress urinary incontinence. But as we all know, and I don't want to talk much about it, after the FDA warning and the problems with some patients, and especially their lawyers, we had some changes in the surgical trend. And in this study, we can see how, after the FDA warnings, there was a decline in the procedures that were followed by and preceded, of course, by removal of these slings. And we see how the performance of the TOT and TBT declined with the warnings, and how there was a slight improvement in the number of procedures performed with bulking agents. And that was the truth. No, that's what we can see in England, but also in other countries. Without slings, some authors have thought about performing other older procedures. Some of them open, some of them with the laparoscopic approach. But why were they not performed with the slings? Because they had a higher mobility and also a longer surgical time. So people were also looking for a substitute of the slings that could have also its advantages. If we had a look at the guidelines, we see that the bulking agents have a shorter-term improvement, but the most important thing is the short surgical time and the low adverse events. So that's what I call the new hope of the surgical treatment of stress urinary incontinence. But we have several or components in the market, which should be the ideal material is that is biocompatible, has got a good integrity. The volume should be retained and also incorporated in the host tissue, and is one that is easy to prepare and to implant. Of course, it should not induce allergies, inflammation, tumoral growth, fibrosis, or it should not migrate or biodegrade. So we've got two types. I guess you already know that. The ones we have particulated gels, and others are homogeneous, not particulated. The difference is that the non-particulated are biocompatible, have better integration with the tissue, is resistant to migration, and it doesn't generate any adverse tissue changes. On the contrary, the particulated gels develop a chronic inflammation response that is why they get encapsulated and is the reason why they generate this bulking effect. The non-particulated homogeneous gels are bulky because the volume you inject, because they don't get degrading. This is the case of collagen or Balcamid, and the examples of the particulated gels are macroplastic or Deflux that you for sure know very well. There was a Cochrane review conducted some years ago, 2017. They included some of the devices or the components that we have in the market, and they included 14 studies. What they say is that you cannot use autologous fat. Some of these components were already withdrawn from the market. We see now why. And that the silicone-based are better than the collagen. But they cannot say which one is better than the other with the studies that we have now. And I said that some of them are already withdrawn from the market. Why? Because sometimes they are like the wolf in a sheep costume, and they are not so good and so naive as we think. In this review, you see Irving, that is there with you, is one of the authors. They had a look at some complications like retention, hematuria, particle migration, biannual wall erosion, and they conducted a very extensive review. And as you see, you've got some components like Balcamid with 18% of complications, or Tegres with 13, but others like Suidex had nearly 50% of complications and a 5% of Clavian-3 complications. Urolastic has a lesser total number of complications, but the Clavian-3 complications are 11%. So maybe some are withdrawn and others should be withdrawn in the future, but we'll see. So from the different elements that we have, you see that some have been withdrawn because allergy, embolism, abscess generation, or because of a high migration. We know that we cannot use autologous fat because of the risk of fatal pulmonary embolism, and the association with the dextranomere and hyaluronic acid because of the risk of pseudoabscess formation. Okay. Some of the criticisms of the bulking agents is that some people believe that they don't have long-term follow-up. So I'll show you some studies. This one in 2012 with a 2-year follow-up in 135 women. They show that in the in the long term, in these 2 years, there's a decline in the percentage of improvement or of response. But important thing here is that although these patients have got a decline in the time of the effect, the ICQ scores over time is maintained, and also the quality of life reported by these patients, but they didn't use a specific questionnaire, but the visual analog scale. This is another study with Balcamid in 3 years follow-up, and they show similar results as you see. that they have in the first 3 months 93%. After 3 or 4 years, they've got a 74%. There's a little decline in the percentage of success or improved patients, but the ICQ and quality of life scores are maintained. They also reported the complications that are not such severe, like de novo urgency, post-injection UTI, or temporary urinary retention. From these 256 patients, they only radiated 18 times. And this year, you can find in the Neurology and Urodynamics journal this study with a 7-year efficacy and safety outcomes. And you see they have treated 1,200 patients already, although they only analyzed 388 because were the patients that had reached this checkpoint of the 7 years. There are patients with a mixed urinary incontinence with pure stress. They also had a 4% of patients having repeated injections 3 times. A third of the patients needed 2 times this injection. And many patients also had prior surgeries, so they were not surgically naive. However, they had 50% of patients improved and a 16 cured. It's true that the 20% nearly underwent finally another surgery, but the response rate is quite good. They also shown significant changes in the decrease in pad use and improvement in quality of life in the questionnaires. And also important, they reported the complications rate that are also not severe in these 388 patients. And you see that the number of patients having a complication is very low. Another concern with these bulking agents is the number of injections. And one thing that has been seen is that the rate of repeated injections is reduced with the experience of the user. And also that there's a very low percentage of patients needing really re-injection. Or as you see in the graph on the right side, there are some patients that don't want to have a new injection from those that are not improved, but it's of course patient selection and one of the things that we have to discuss with them. We also have now some studies comparing the bulking agents with the mid-urethral slings. You may know this one. Was presented in the American Urological Association meeting 2 years ago, and it is also now published in a paper with the first prospective randomized and controlled trial comparing Bulkamid with TBT. And what they found is similar to previous studies, that the satisfaction with the TBT is greater than with the Bulkamid because they get better results in the calf stress test after surgery. But these patients also have more, or they have complications in the TBT arm, but patients with Bulkamid did not report complications. So what the authors say is that the Bulkamid can be offered as a safe first-line treatment, and if it fails, you always can perform the TBT. So you can offer the TBT to those patients who wish a complete cure with the first treatment, but always knowing that they got higher risks. So you have to explain that to the patient. And what they discuss in their full paper is that, of course, the TBT has got a higher satisfaction rate, the subjective cured and improved patients, and more patients are objectively tried. But they also have a higher risk of serious complications. On the other hand, you've got the Balcamid that has got a lesser efficacy, but also a very, very low rate of complications. So maybe the balance is more balanced, so to say, as with the TBT. Have we got some predictive factors for success? I have selected some papers. I like this one. Is from 2019, where they saw which were the demographics of the patients. And as you see, the only factor that was significant was the number of injections. We need to know when talking about the efficacy and the cure or improved rates, that in the first studies using the bulking agents, we had only 2 injection sites. And then someone thought that maybe it could be better to do this like Mickey Mouse silhouette with 3 injection sites. And nowadays, most people, most surgeons use a 4-site injections. And as you see in the table, improved incontinence was more likely to appear with 3 sites injection and no improvement with 2 sites. So the more the more sites you inject, although the volume is the same, the better the continence. This is a post hoc study trying to find out these predictive factors in nearly 300 patients. This part is in Spanish. They were controlled 1 year, and they performed a multivariate analysis. They found 25% of patients that were without stress urinary incontinence episodes in the bladder diary or in the ICQ questionnaire. 56% improved and 80% not improved. And what they saw is that patients older than 60 years and having less than 2.5 episodes of stress urinary incontinence per day could reach a higher percentage of improvement and cure rates than patients with less than 60 years and more than 2.5 episodes per day. So maybe it could help us when selecting our patients for the surgery. But we also have to discuss with the patient and know exactly what they want. What do patients prefer? You can find this study that is quite good about the preferences of patients when they were given the option to get a bulking agent or a mid-urethral sling. And they asked them why they selected one or the other. And we see the first graph is for the patients that preferred the mid-urethral sling surgery. And what we see is that most patients selected them because they were unfamiliar of bulking agents, because they wanted only one surgery and get rid of the continence, and because they had fear for silicones. But the patients that selected bulking agents, that is on the bottom, decided to get the surgery because of the quick recovery, because they didn't need any general anesthesia, and because they were less invasive. So as you see, patients didn't select the slings because of the slings themselves, but because they didn't know exactly what the bulking was. So maybe it could be different with the non-particulated gels. The cumulative experience that we have now. And I really like this one, with the voice, your choice. So they asked, they saw patients undergoing bulking agents, colposuspension, suspension, facial and synthetic slings, and asked them why they selected each other. They saw the effects, and they analyzed how patients reacted. And they saw that patients that wanted really to be dry selected other options than the bulking agents. But the patients that didn't want to have any type of complications were more prone to select the bulking agents. So what they propose is that maybe you can offer the patients step-by-step treatment, beginning with the physiotherapy, and maybe you can make a trial with the bulking agents before going to more invasive treatments. So as take-home message, I wanted to highlight that the bulking agents can be used both in naive and failed patients, that it is important to choose the agent with the best long-term results and the lowest complications rate, that although the technique is easy to learn, the longest the experience, the better the results, and that we should inform our patients that the incontinence will probably improve and not get cured. So thank you very much. And on behalf of Dr. Castro, I want to invite you to come to Vienna next year. I know that the virtual meeting has just ended a few days ago, but they are still working, now working on the new meeting. So thank you very much.